right. We're just getting the, I'm going to get the YouTube thing going, and then we'll go live as soon as that's over. All right. All right, folks, we are good to go. Those of you who are watching on YouTube, you're behind the scenes with our esteemed roundtable, and we're about to go live in front of our webinar audience on Zoom. So here we go. Hello again, everyone. This is Eric Glazer, and welcome to our live recording of Bright Spots in Healthcare, produced by Shared Purpose Connect. Each episode, we bring leaders together to inform our audience, but also unearth bright spots, successes at health plans, provider organizations, and other healthcare-related companies around this country. Our goal is to identify as many bright spots as possible so that you, the listener, can determine if the ideas shared on our show can be applied at your organization. We believe that this approach of finding a bright spot and cloning it is the most effective strategy to improving healthcare in our lifetime. If you are new to this show, to this webinar series, if you're listening to my voice for the first time, I assure you there are some incredible guests that we've had on the show this year and the years before. I encourage you to go to wherever you consume a podcast and type in Bright Spots in Healthcare, and my mugshot will pop right up, and click subscribe. And that way, every week when we drop an episode, you'll get all of that great information downloaded immediately to your tablet. It's a great way of staying abreast of all the cool things going on in our industry. Our sponsor today is none other than Healthy.io. They are the global leader in turning the smartphone camera into a clinical grade medical device for at-home urinalysis and digital wound management. Their at-home kidney test, Mittal Kidney, aids in the early detection of chronic kidney disease and helps close gaps in access and care for over 500,000 patients worldwide. You should check them out at Healthy.io. I was just having a conversation with a leader at a health plan today, who will go nameless, and we were talking about chronic care and whole person care, and they literally had a Healthy.io kit on their desk earlier today. So check them out. They're doing some incredible work, and they're doing some things for the first time that no one else has done. Our topic today is proactively managing risk via last mile care, and we have an all-star panel that you see in front of you if you're watching via webinar, and you're about to meet if you're listening via the podcast. You're going to, if you want to check out their bios and get an understanding of who they are, our producer Gene Ware is going to post a link to their bios in the chat if you're watching live, and certainly they'll be in the show notes of your podcast description if you're listening on a walk, a run, or just at home right now. I want to quickly introduce them at a high level without getting into their bios. Our first panelist, in any order, of course, is Dr. Pooja Mittal. She's the Chief Health Equity Officer at HealthNet. We also have Dr. Mushir Hassan. He is the Chief Medical Officer at Network Health. We have Megan Schmidt. She's the Senior Vice President of Employer Solutions at Priority Health. And we have Dr. Jonah Menk, Medical Director of Healthy.io, who is in the process of traveling and in a quiet confines of an airport as we speak. And we're going to look forward to all of their great insights in just a moment. I want to start here, folks, with talking about last mile care. And when I hear last mile care, and when I speak to people about last mile care, one of the first concerns is always around disjointed care and uncoordinated care. So for those who may not know of Priority Health, I want to introduce Megan Schmidt. Megan, if you could just quickly tell us who Priority Health is in about 15 to 20 seconds, and then talk about how you guys are enabling closely coordinated care between care at the home and the individual's primary care physician.
Sounds great. Thanks for having me, Eric. I'm excited to be here. For those of you who don't know Priority Health, we are a 1.2 million member health plan based out of Michigan, doing employer, Medicare, Medicaid, and the individual market. We're part of the integrated health system of Corewell Health, which is the third largest integrated health system in the nation. And we work with providers outside of our health system as well. So we're known in the industry for quality, customer service, price transparency, and innovation. And I would say probably the other piece that we're known for is that personalized care, which probably talks a little bit about what you have me here today discussing, and how do we work with members differently thinking about our payers out there who are not part of an integrated health plan, or thinking out the providers that are out there about how can they say, we want this ecosystem of a connected member experience. And you have to be really intentional on how you do that. And so your question to me was really hitting home because it happens to be in a variety of different ways, digitally enabling them, keeping that personalized care. So our clinical care team at the plan, also connecting with providers from a clinical perspective and making sure that we're creating that ecosystem. And so I call it an environment of connectedness. And so, Eric, for me, this is a really exciting topic to share success that we've had and obviously still spaces of learnings as well.
Oh, can you speak a little bit about high level, like how are you connecting, just high level, how are you connecting individual physician with data collected at home? And then how are you measuring any impact that's making? Like what areas are you looking at?
So I think there's kind of three critical areas. So that virtual connected, and I'm not just talking virtual care, acute care, looking at specialty and chronic disease, virtual access, health coaches, health navigation, using, medical devices that are technology enabled. So digital scales that we're sending to the home, technology that's able to, take vitals and those types of things that are connecting the clinical teams with real-time information. And then trying to be innovative in saying we need to connect back to the provider community, both with data, but what's also happening so we don't have a silo of care as we're working together with members. So we've connected into electronic medical records, like, making sure that we can use our systems of data and put it right into an EMR at a provider office. So there's great learnings that we have of being part of an integrated system, but we also do that with non-owned providers in our system to make sure that we're able to exchange data. So a couple of highlights that would be meaningful. So 89% readmission avoidance, which is the lowest in the state of Michigan. So we know that we're keeping care coordinated and keeping people out of the healthcare system when they don't need to be in it. So readmissions is a really important piece. ER and urgent care reductions, 6 to 10%. So we know that when we're keeping people with access to care and making sure they're getting the care that they need, treating chronic disease, that we're also giving them that triple aim, which is right care at the right place and the right time. And then I would also go into chronic disease as well and say that when we're able to engage members in our engagement, including in virtual capabilities, digital capabilities, upwards of 60%. We're seeing national averages at 13. So we think 60 is pretty outstanding. We're seeing, increases in medication adherence. So 5% as an example in our diabetic population. And when we've been able to have that technology enablement in the home, digital scales, taking HbA1c levels, we're seeing weight loss, and we're also seeing, again, our diabetes management, just as an example, being very successful. So that connectedness becomes really important.
Really, really enjoyed hearing that. That's really insightful. And I want to introduce everyone now to Network Health and their chief medical officer. I believe Network Health is a 5-star MA plan in Wisconsin. And Dr. Mushir Hassan is their chief medical officer. Mushir, can you tell us just quickly, again, 10, 15 seconds about Network Health, if anyone listening has not heard of you guys, and then talk about how Network Health is leveraging at-home testing in their Medicare Advantage and last mile strategies overall.
So if you take the ferry across Lake Michigan, we're pretty much mirroring what Megan's doing at Priority Health. We are a provider-owned health plan in Wisconsin. We have about 112,000 members, primarily Medicare Advantage. We've had some really good success in being able to outreach this population in particular with the work that we've been doing with both at-home testing as well as kind of engaging members that are on the pathway towards type 2 diabetes that are starting to show elevated blood sugars. We've had some success, especially learning from the pandemic about how to reach members at home and being able to get kits into the house, both from a colon cancer screening standpoint. We've actually got HPV testing for cervical cancer screening, and we're doing A1Cs at home. And we found really good uptake with our members that prefer to have the ability to have some care gap closure that we can do by getting kits to the home and getting some information back to us. I think that we've really been able to build up that track record where information as well as communication from Network Health is well received by our members because we have a personalized approach to what we do with our members. One of the things that you want to really look at is you can have technologies that are out there that people want to use, but what's your engagement index that you get with this? And that comes from having a health plan, I think, that is local, that is able to build up trust with your membership, that people will pay attention to what you have to send to them.
Yeah, I want to get into engagement later on. Is there a particular area or disease state or chronic illness where you guys are seeing any increased success beyond everything else you're doing as far as at home?
I think from one things we like to highlight is our type 2 diabetes program. We've taken the CDC guidelines about how to prevent type 2 diabetes and put it into a program. We've had about 6 cohorts that have been running since April 2019. We get about 15 to 20 Medicare members into each cohort. And I can tell you that we've been able to track the success over the course of a year. These members will log in over 100,000 activity minutes as a group. We've been able to lose, probably 200 pounds in the first cohort, 200 pounds in the second cohort collectively. We've really had good success with getting people to engage. And I think that the camaraderie that's been built up with those groups allows us to actually have alumni groups now that still continue to meet to reinforce positive behaviors.
Oh, I love that. We just did the episode before Thanksgiving. We did on peer support. I'm a big believer in that. Can you tell us a little bit about the cohort? So as people are thinking about maybe a similar program, like how did you think about dividing up the cohorts? And if I heard you correctly, 15 to 20 members per cohort.
That's correct. It's the key thing, I think, is to really devote some attention to having a structured wellness program in place within the health plan and having a wellness coordinator that's been educated about this. And for us, I think we have the luxury of having provider systems in which we can engage with our dietitians as well as our diabetic educators to get really good information back to our wellness coordinators to share with these groups and to really have engagement with the wellness coordinators first, but then to show the members that we have endorsement from the health plan. I've actually been a guest speaker. Our CEO has been a guest speaker. So that way the members know that this is a priority for us as a health plan, and they're able to get feedback both from a teaching standpoint, but also from a leadership standpoint to show how the program is valued for each of the members.
Last follow-up question, Mushir. So you said, if I heard you correctly, 2 cohorts at 15 to 20 members. So that's 40 members right now. Did I hear that correctly?
That's correct. And then one cohort is about 3 months ahead of the other.
Okay. Is there a plan to scale this? And if so, how? Like, what would be like a high level? Like, how are you guys going to think about scaling it?
Well, I think that the way to scale would be, can we, I like to say, quote, franchise it into a service that we can offer to some of our primary care groups that we have? Because there are obviously in this space, you've got folks that are geared towards weight loss. We like to be geared towards more health plan endorsed tactics that allow for folks to be able to not only lose weight together, but also then to have some degree of ongoing feedback from the health plan for healthy chronic disease management behaviors. Because once you've been able to reach these folks, the likelihood of being able to engage them for other metrics does significantly rise. And we want to be able to touch a lot of chronic condition management with this as a lead-in to get people engaged.
Yeah, that's really, there's a gentleman who's been on the show, maybe it's been a couple of years ago, Dr. Wayne Altman. I think he's out of Tufts. He has a very similar program and he franchised it out just like you're talking about. If you want me to make a connection with him, tell me after the show. We could do that. He was been on the show, I think, in 2020, 2019. Okay, I'm going to bring in Dr. Jonah Mink. He is the medical director at Healthy AO. Jonah, as it relates to chronic diseases like diabetes, what is often the gap in care that you see in Medicare populations, and how are health plans addressing those? Is it similar to Mushir and Network Health, or are there different approaches that you're seeing?
Yeah, so thank you to both Megan and Mushir. I think that what I've heard from both of you is that you're engaging people as people, right? The patients as people. And sometimes it's hard to remember that, but what are we trying to do, right? Like engagement is, where's the gap in engagement? You have to stimulate the feeling of value within the person themselves, right? So the idea of reaching out, having small cohorts, stimulating that sense of belonging, connectedness, I think that's really wonderful. When you have a chronic disease like diabetes, there's so much to keep track of. Like, you have to do so many things. Like, when you move from being non-diabetic to being diabetic, there's like 20 things you have to track all the time. You have to go to your doctor for blood tests. You have to take your medications. You have to get an eye exam every year. You have to do a foot exam every year. You have to do an ACR test. You have to do a GFR test. Like, trying to do that, just like remembering my task list, is impossible, and I don't have diabetes. So putting that all on the individual is a recipe for disaster, and that was an old model. So how can we support the physician groups? How can we support the patients as people, and how health plans are looking at the data points that they have access to, like you guys are doing, and figuring out how do you weave those data points into figuring out who qualifies for these cohorts, and then what are the interventions that have been proven, what are the interventions that kind of engage people as people, and then out of that engagement presents the data back to where it needs to go, both to the patient for reinforcing that motivation, and to the clinician so that it's actionable at the right time, and then feeding back also to the health plan to make sure you're moving the needle. And so I think that, one of the major gaps, just kind of bring it back around, is that people are just overwhelmed with how much they have to do when they're sick. It's paralyzing. I see it in my patients a lot. And so can we create these human-centered design, like Megan was talking about, and also that's represented in your programs, I'm sure, about that bring the patient as the human being at the center of the story? How can we motivate them and reduce the burden for them to keep track of all of these things by weaving in these different streams of data that are presented when they're actionable, and to whomever they're actionable to? So whether it's monitoring devices at home, home-based testing, or home-based blood pressure monitoring, whatever it is, wherever that's going, not saying, oh, you now have to do this, but saying, hey, we're going to do this together as part of this cohort. This is going to be fun. It's going to be easy. It's going to be engaging with technology now in this new era where we can make the experience of actually using these things not a burden, not a task, but as part of your life, part of what you want to do, part of what's kind of intrinsically motivating for you to do. And it's something that we've fully embraced on the Healthy IO side of how we kind of weave that in as one of those data streams that's minimally burdensome and potentially quite engaging and fun to do, and easy in the comfort of their own home.
Like that. I like that a lot. We're going to get more to that in a little bit. I want to introduce everyone now to the Chief Health Equity Officer at HealthNet, Dr. Pooja Mittal. Pooja, could you tell us maybe 10, 15 seconds about HealthNet? Because my guess is some folks outside of California may not have heard of you guys. They will once you describe it, I'm sure. And then how are you guys approaching chronic care and supporting consumers in the home?
Sure. So thanks to everybody. It's been really interesting to hear what everybody's talking about. And I think there's this theme of personalized care, right? And so a little bit about HealthNet. We're a Centene subsidiary plan. We have 3 million members in California. 2/3 of them are Medicaid and the rest are commercial, exchange and Medicare. And we have a footprint that's pretty broad across California. So that gives us a varied population, including people who are rural and urban, and then all kinds of race, ethnicity, language. And so part of how we approach this work, I think similar to what you all are saying, is we start with a data-driven approach, really trying to understand who our members are. And we put them into this 3D, what we call a 3D population health pyramid, right? So we're all used to thinking about a population health pyramid where the sickest people are at the top and sort of the preventative care is at the bottom. And what we're trying to do is really ensure that we're thinking about population health along with quality and health equity and putting them in the same pyramid. So we layer HEDIS into the same pyramid. We layer race, ethnicity, language lenses and health equity lenses into the same pyramid. So that allows us to think about our populations, not only from a quality perspective and to align our work that we do, our resources that we put in from a quality and population health perspective, but also to be taking a health equity lens, right? Really focusing in on the places where we need to do the most work and to support people in the closest way.
Right. The Pop Health Pyramid needed some innovation, so I'm looking at that. Do you guys have anything in the public domain that Gene or could go find and post, or is it sort of considered proprietary?
Well, we're still finalizing all of it, and it probably is considered proprietary, but if I can share, I will.
Okay, I want to ask you actually about an example that comes out of that strategy. Before I do, I just want to make a quick announcement. So those of you who've been listening to the show for a while know that I really believe in like the roundtable format and bringing really smart people like you see before you today to share ideas and have a discussion. And so what we're doing for the first time this next summer, August 2023, August 22nd and 23rd to be exact, on Boston Harbor at the Marriott, we are going to host our first executive summit roundtable. And it's going to be designed for providers and payers who want to come in and cover issues around health equity, consumer communication and engagement, talk about care models, and really focusing on whole person as a strategy for a day and a half. But rather than listen to a lot of presentations, maybe hear one plenary roundtable or presentation, but spend most of your day interacting with others and facilitate a roundtable discussion, sharing ideas like you see before you today. So a very different model from a traditional conference, a little smaller, a little more intimate, and designed that you could share ideas and meet a lot of folks from around this country that work at organizations like yours. So if you want information on how to get a pre-registration rate to go to that event, which I'll be hosting, of course, and my team will all be there. And we're going to have a lot of fun and get a lot of good work done. Happy to send you an email with information about how to save about 50% off and get all kinds of interesting pre-registration kind of benefits. Jean's going to put up a poll. If you want us to send you some more information around that, I'll email it to you later this week so you get information about our first Bright Spots in Healthcare Executive Roundtable Summit, August 22nd and 23rd. So I'm going to now ask you, Pooja, for an example. So like, what's an example of a program that has kind of been born out of this 3D model that is actually moving the needle?
Yeah, so I know we've been talking a lot about chronic disease programs, so I'm going to kind of go off in a different direction. And we have a program called Start Smart for Baby. That is a longitudinal case management program that starts in the prenatal period and follows people through postpartum. And actually, we're adding a first year of life component. So the program is going to continue through the first year of life. And as we identify people for this program, we do it through stratifying them by high risk, moderate risk, or low risk as pregnant people. And we also apply a race ethnicity lens, right? Because we know that Black women and Native women or Native pregnant people have a higher risk of having poor outcomes during pregnancy. And so we really try and hone in on that population and try and provide the best longitudinal support that we can. And from this program, I mean, it varies a little bit based on each cohort that's going through the program. And we're not really powered, right? You really have to power at quite a high level from a population level to look at a reduction in preterm birth. But from our last cohort, which is about 550 women, we saw between a 25 and 40% reduction in preterm birth, which is phenomenal, much higher than you would anticipate to see from a model like this. But I think it speaks to, what others were getting at too, what you're getting at, which is how can we engage people to remain healthy through a partnership type interaction so that they're not feeling like they're out there doing this on their own.
What would you say, Pooja, would be like, if you had to say like 3 key pillars to making this program successful, if you could lay it out for us?
Yeah, I think one is the way that we identify the people who should come into the program. So we do a really solid vetting process. 2, we have very experienced nurses who develop a longitudinal relationship with people, and people feel like they're supported by that same person throughout their entire journey. And 3rd, I think that we really do take as a health plan a family-centered approach, right? A longitudinal life course perspective approach. So we're providing people with digital tools and other adjunctive tools that they might be able to use that would support their overall health on their journeys. And again, like, we use every opportunity that we can to look for social needs as well. And so we also try and support people's social needs. And I think that goes a really long way with people feeling like we do really care about what they need to have a healthy pregnancy. So we provide support around food insecurity, we provide support around housing, and fill those needs as well.
So identification, analytics, making sure you have a well-trained group of nurses that are going to engage and create that great member experience. Overall focus on family centricity and longitudinal care for number 3. And then the 4th, which was a bonus. This is great.
Yeah,
Was social determinants of health focus.
Yeah.
Needs focus. Great. I appreciate that. The poll that you see there, folks, is not about sponsorship. I know Gene said that in the chat, but in case you missed that, it's all about, do you want more information? And just yes or no. We're not asking you to sponsor. And incidentally, if you're just listening to this on the podcast, email me directly, eglazer@sharedpurposeconnect.com. That's my personal email. And I'll send you more information. So, Jonah, I want to shift a little bit back to chronic illnesses and maybe even diabetes. I mean, how can you provide examples of how health plans that you're working with are risk stratifying within the population suffering from diabetes? And I know you alluded to this in your first answer, but how are you identifying and testing for like higher risk, higher cost cohorts within a diabetes population like CKD?
Yeah, so I think it's really interesting what you were saying, Pooja, about building that pyramid. And I think it's, we can all learn from this theme of like, you have to balance the risk. How are you risk stratifying people, right? You risk stratify by using data streams, by these data inputs that are coming in. But you only have so many data inputs that you can get from a patient before they get overwhelmed, before they feel like they're working for you instead of you working for them, right? So, balancing that with this human-centered approach of wanting to make it easy, fun, and interesting for them to provide data points that go into informing risk levels, right? That these risks are based only as good as the data that's coming in to inform the models. So you have to choose very, very wisely and selectively what data points are going to be the highest yield for you to inform your models so that you can focus on finding the cohorts, Mushir, that go into that fit those 25 people, those 15 people. Like, you can't get all of the data you would want. Like, you can't have them just be in a lab and be poking and prodding them and getting all the little data points you want. You need like 2 or 3 or 4 things that they're going to do that allow you to optimally risk stratify. So you want to find the biomarkers or the measurements that are most closely correlated to what's the risk, right? To morbidity, mortality, and cost. These are the biggest issues, right? And so whether it's equity measures, whether it's urine albumin creatinine ratio, like we're doing in Healthy IO, whether it is blood pressure, whether it's, some other, smart marker that you have to choose only a few of them that people are going to be willing to give you. And so I think that, and that makes all the difference, because once you're able to risk stratify, you're able to really, really tailor these interventions to optimize the movement of that needle. And so, for instance, with Healthy IO, we are measuring in the home albumin creatinine ratio, which is very highly correlated independently with cardiovascular morbidity and mortality, progression to end-stage renal disease, and death. Right? That's a very high yield metric. It's part of the new HEDIS KED measure. It's being recognized more and more, and adherence to it is super low. So can you get people to give you that data so that you can build that into your risk stratification model around these negative outcomes? So I mean, it's interesting. Like, you take someone with stage 3 kidney disease, like a GFR, in stage 3, and if you take that person and they have no albumin in their urine versus if they have very high albumin in their urine, they're at over 4 times the risk of having a cardiovascular event within the next 5 years. And they're also, from a cost perspective, more than doubling what their cost would be to the plan within that same period. So, these metrics can be very, very impactful for how you include people in your cohorts. So I think the point that I'm trying to make is that figuring out what the intervention are, what the service provider is that you engage in your models that can be low touch, motivating, personalized, that people will want to give you their information for and do and actually complete. Those are the ones that you should focus on engaging, that give you the measures that really move the needle when you intervene appropriately. And then you can build your risk stratification cohorts, because you only have a few chances to get people's attention, and to actually have them want to be intrinsically motivated to complete these measures so that you can get that data.
Yeah, that's good stuff. It strikes me, Jonah, that your colleague Donna had shared with me this white paper you guys sort of produced. I know you had some authorship, but there were some other clinicians that authored it outside of your organization, called The Missing Metric: How Health Plans Can Improve Risk Assessment and Quality Measures. I'm going to ask Donna if I could send that out. If you guys want a copy of that, so you don't have to go through a gate or do any registration, let me know. Gene, why don't you put up a poll here? It's actually a guy from Johns Hopkins University, Dr. Yosef Koresh, and Carrie Wills, the Chief Scientific Officer at National Kidney Foundation, had a big part in this paper. So it's not necessarily like a marketing piece per se. Of course, Healthy IO has produced it, so there's some branding there. But I think it's really interesting, and it's a lot of they take the data and put it in a lot of easy to read charts, and felt like USA Today, so I could read it. It was really interesting. So highly encourage you guys to take a look at that if you really want to get a sort of a bird's eye view in writing of what Jonah was just trying to describe. Let's stay on diabetes for a moment, Megan, and let's talk about how Priority Health is supporting the treatment and management of chronic illnesses with your members at home.
Yeah, I mean, obviously, we all know why we're here talking about the prevalence, unfortunately, of chronic disease and also the cost that's there. But, certainly what it's also doing to, the membership, the quality of life that they have. I work in the employer market, right, where people want healthy, happy, productive employees, and they're providing health insurance as a benefit because they want to enable that engagement in the workplace. And so I can continue to build off of what we've talked about, and I've appreciated everybody's insights into a real understanding that data is very meaningful, but it's not data for the sake of data, right? We've got more stats than a baseball team coming out of us on a daily basis. So what you do with it becomes really meaningful. And I think the best thing that you can build is kind of, a portfolio of different levers that you can pull to get to that personalization. And so I think something that we've kind of failed at sometimes on a health plan is saying there's a one size fits all approach. We found one program or something, right? And that's going to meet the needs for everybody. And so what I'm hearing my colleagues talk about here today is multiple interventions. And so when we talk about chronic disease and diabetes, it is about personalized care, but it's about marrying that data, marrying maybe some, exchange of data. We talked about digital enablement at home. The way Jonah describes it and the way I've talked about it as well is it's like a personal trainer now that you can't lie to because there's too much information, but you're engaging the member in that information and that data share. So whether it's through motivational interviewing, right, with your clinical care team, a big piece of what they're trying to talk about is before we can get to talking about your diabetes, we need to establish some trust, and we probably need to talk about maybe your underlying conditions of depression. And so when you can start with those milestones and helping a member build trust and see that they can have engagement along the way, to me, that's what we have found a great success in, keeping it simple. The newly diagnosed diabetic that is overwhelmed, we just start with, do you understand your diagnosis? And then we'll help them also navigate to understand your benefits, right? They're now maybe using things that they haven't used before. And so not only does that make them a smarter consumer, but they're feeling more empowerment in managing their conditions. So a lot of what we've talked about comes together in a variety of different ways, but not that one size fits all approach. So multiple programs, meeting people where they're at, multiple ways to help them engage digitally through coaching. Another tie that we talked about, and I think you're seeing this in some of the cohorts that my friends in Wisconsin are doing, care is still local and people still like that personal connection. And so you can do community groups that are digitally based, that are chat features. There's reasons that we like social media. So there's still an ability to connect in a variety of different ways. That's some of the success that we've seen that doesn't just drive short-term engagement, but keeps people engaged over the long term. These aren't things that just go away in 6 to 12-week programs.
I don't know if I'm putting you on the spot here, Megan, but do you have like a high level overview of some of the results you guys have seen through this one size does not fit all strategy?
Yeah. So I think when we look at digital enablement, this is where we start to see those medication adherence. I'll give some diabetes as an examples, but we see it in cardiovascular health as well, that when you're getting people well managed, so an example, they start to become well managed on their behavioral health medications. We've been seeing through data, they're not taking them consistently, they're not refilling them. So when we get people stabilized there, we're also seeing reduced cost in urgent care and ER for some of those types of conditions. But then we're able to engage with them in managing their chronic disease of diabetes a little bit better. Where we've started to see, measurements is looking at not just progress of weight loss and blood sugar, but we're also seeing their increased activity. So we talked about that whole person. And Pooja, when you were talking about how do we get preventive health back at the top, we're driving in those preventive health measures. And so we're seeing that engagement then is also reducing the cost that the members are spending, but the cost of the health plan, and in some cases our self-funded employers are spending. We see this also happening in Medicare and Medicaid in the individual market. So multiple levers that you're pulling, and then you're seeing multiple areas that you can see outcomes of both clinical quality of life of your members, and then cost, because I did talk about the triple aim, but the quadruple aim is also saying at the right cost. And that's a huge piece of the equation.
Yeah, I'm gonna come back to you in a little while. I want to talk about modeling because I think we're onto something. This is really interesting. But before we do, I want to make sure we can't get into modeling until we get into communication. And everyone's been alluding to communication and trust throughout today's discussion and within their answers. I'd love to learn a little bit about how the group is continuing to build trust and how they're ensuring that the member feels connected while at home to their provider. So, Pooja, why don't you go first? And what's happening in your neck of the woods as far as connecting, making sure that Health Net members feel that they're close with their provider, even though sometimes they're getting a lot of their care at home.
Yeah, thanks for the question. In the end, it comes down to just a lot of hands-on work. So it feels like when we're doing a really good job with this, it takes a lot of resources. And I'll talk about one particular example. When we were going through our data, we noticed that there was an area in one of our counties where there was a group of women who had much lower postpartum follow-up rates. And when we drilled down and looked at it, it was one particular clinic where the issue was, and it was a clinic that had a very high percentage of El Salvadoran women in the clinic. And so as we dug into, our medical director and our quality team sort of went out and started talking to people. And as we dug into it more, what we found was that these women have a tradition, a postpartum tradition called cuarentena or quarantine, where they stay in the house for 40 days after delivery. It's a very common tradition in many cultures. And as we started talking to the providers were not aware of this tradition. And so we're not accounting for it when they were counseling people about postpartum care, and we're not necessarily working around it. And so we pulled together a group of providers, a group of community members, and a group of our own members to brainstorm around what interventions might be able to improve that communication. And in the end, there were a few different things that we ended up doing. One was creating a set of educational materials for the community about the importance of postpartum care. And then the second was actually putting in a question in the EMR so that the providers would be triggered to ask the question about whether they followed that tradition, so that they could then talk to them about it and talk to them about the importance of coming into postpartum care. And through this intervention, we were able to improve postpartum care rates in that population from 50% to 82% over the course of a year. And I think it sort of mirrors a lot of the work that we do at Health Net, which is geographic based and population based, right? So we really come into a community and try and figure out what the strengths of the community are and how we can use our data and our support to be able to improve a disparity gap that we see. Another place where I think we did this very well is during the COVID pandemic. We found that there were certainly populations where there was much less uptake, right, of the vaccine. And some of this was driven by culture or biases. And then some of it was really driven by unequal access in a lot of ways, right? In urban areas of LA, you would think that there would be really good access to vaccinations, but actually there weren't good off hours vaccination access. And also they weren't coming from trusted partners, right? People felt like they could trust to go get a vaccine. And so we ended up doing a series of events that were called, we put together a campaign called the RVAX campaign. And we put together a series of events where we supported local CBOs to pull together these family-focused, very family-friendly events on weekends, where they would bring in a local provider to give the vaccines, but then also other organizations within the community that were trusted, faith-based organizations who would do fun things, like concerts or, bring food. And then we also supported local Black-owned businesses, Latino-owned businesses to do giveaways so that businesses also showed up in those places. And we had feedback from so many of our communities that they were just so excited to have funding to bring the entire community together in a way that was supportive of the community while also providing a service that was really important with the vaccinations.
Wow.
And so
we
did these across the state and gave out over 22,000 vaccinations. But mostly, actually, I think the biggest success was not necessarily the vaccines. I really do think it was building a sense of community when people really needed it.
I love that. I was going to ask you about results. So the 22,000 sort of answers that question. What about for the program when you identified El Salvadorian women? Do you have any clinical results there or engagement?
The increase in the postpartum visit follow-up. So 50 to 82%. So much higher postpartum visit follow-up, which we know leads to better outcomes. Yeah. And helps to build that relationship, right, between members and providers.
Yeah, I'm a big believer in local as a healthcare strategy. We're going to cover more of those topics next year. Can you, Mushir, give Network Health's kind of perspective to local as a strategy, and what are you guys doing to build that ongoing relationship between individual person and someone, a provider or someone at the health plan?
Well, first I'd say, Pooja, I think is excellent work with the El Salvadoran women, just kind of a great C-suite example for how to meet members where they are. I think that taking that same approach has been prevalent in our own C-suite of being able to really engage our population, understanding our population and who they are, to be able to better service their needs. We have experienced a lot of growth the last couple of years in our membership, in particular Medicare Advantage. And so we've been able to undertake new member orientations as well as new member teaching and education sessions. So that way people can fully understand their benefits. Obviously, the marketplace has gotten a little bit richer with ancillary benefits, and making sure that our members understand what's available to them and how they can get reimbursed for other things that can help to augment their care has been important for us to do that as well. Similar to what you heard from Pooja, I think that we also like to be out in the community and being able to do community events. We've got a partnership actually with a local art museum where they have art and wellness as a monthly event. I've had a chance to go and speak there to talk about some wellness events and actually go on a wellness walk where we talk about medical tidbits with our members just to be able to kind of share with them what some of the latest medical news is that's out there that might be relevant for their health. I think it's just finding different avenues to be able to really engage with our members to see how they can best digest some of the medical information that we want to share with them to better augment their chronic disease management. I really enjoy talking about our pharmacists in our program as well, because one of the things as a primary care doc, you wish you had more time to be able to teach. And I think being able to use our pharmacists on the health plan side to be able to teach our members about their medications, about what the medications are for, as well as the opportunity to share with them, hey, there may be some opportunities for you to have some savings personally from a medication strategy where we can help our members actually save money. I think that helps for us to be able to build trust with our members, where we become a trusted partner with them. I can share with you that we've had about $500,000 a year on member savings alone on the member side, where they've been able to really kind of value us as a partner that's looking out for their best interests, and leveraging that to be able to then add further education becomes a lot easier task. So I give a lot of credit to our pharmacists and our new member education team to be able to be the first interaction point that we have with the health plan, and they allow us to be able to then develop that rapport. During the pandemic, I think we were able to outreach to our members with, PPE kits and being able to make sure that they're fully understanding different ways to help keep themselves safe. I know a lot of us are doing drive-through flu shot clinics just to really encourage getting their flu shots, which is obviously very important at the current time as well.
That's super interesting. And obviously, I think we all agree pharmacists are probably need to be leveraged more and more. Any kind of overall results you could share with us at a high level of the RX program?
I think
cost savings or adherence.
Well, I think there's a couple of things that we can show. I think that obviously there's a member cost savings that I shared with you kind of year over year that they've been able to really save on their side. One thing that we like from a health plan side is being able to show medication adherence rates that are starting to improve. And if you can start, going from the 60% to 70% over the last few years, that being a measure that we're tracked on has been very helpful for us to be able to track. The other thing that we're starting to notice is as you're looking at adherence, if there's a dip that occurs, being able to further investigate why that's happening. Something we've been discussing of late the last month is that there's some difficulties that some larger pharmacy chains have had with staffing. And that then affects the ability for folks to be able to get their drugs on time, and being able for us to be able to understand that dynamic that's occurring out in the community can allow us to be able to further interact with the members just to ensure that drugs are getting filled, or if they're getting filled at different pharmacies, being able to track that.
What about technology, Mushir? Like, what are you guys doing to use technology to close that communication with members? I mean, the face-to-face is great, but you also need to leverage the technology. What's working? What isn't working?
So during the pandemic, we were concerned about loneliness, especially for some of our seniors. And we were able to leverage a local provider to get tablets into the homes of members. We got about 900 tablets out in the community, along with Wi-Fi pucks that were in the home to be able to allow communication that could occur via the tablet. There was some teaching that we could do via the tablet as well to push out information. That was well received by our members. But when we asked post-pandemic as to whether or not they wanted to keep it, and if there was a fee associated with it, we still want to keep it, most members told us that, we'd actually rather migrate back to what we already use, which is a smartphone. And so I think one of our big learnings is that a tablet may be something that's neat and shiny that might be useful, but the reality is if you want to reach your members, find out what they're using regularly. And I think for us, one of our learnings that we've had, especially looking at the vendor space, is likely the text messaging method to direct them to a certain either website or another modality of contact is probably the best way for us to be able to reach our members and to really ensure ongoing engagement.
It's interesting. Yeah, interesting. Sort of like life flow. You got to fit in people's life flow a little bit. I want to get into sort of modeling right now. One quick sort of interjection. One of the more popular things we've been doing per everyone's feedback. And by the way, you're going to get a feedback form in your inbox any minute now. It's going to take you 3 to 4 minutes to complete. We really ask you the favor of doing that, all multiple choice. And we get feedback on how to make the show better. What are the topics that you want us to cover? One of the things was, can you help not make us register week to week if you want to attend a live webinar? So next week, if you don't want to register but still want to be registered by us, we're going to put up a quick poll. We're covering whole person care and innovations in whole person care, and it's going to be a blues panel. So we're going to have Blue Cross Blue Shield of North Carolina, Kansas City, and Minnesota on the panel, sharing different things they're doing around innovations to whole person care. 12 p.m. live on Thursday. Anyone who listens to this podcast, same thing, it'll drop on Friday. So you'll have that for you. So look forward to seeing you guys next week. So I want to get into modeling and risk share. I also, one more thing, folks, sorry. I want to give a quick shout out if I don't have time at the end and thank Healthy.io again for supporting this program. We can't do these episodes each week without the great support from our sponsors. And as a reminder, check them out at Healthy.io because as you heard when you heard Jonah talking, they have this incredible home kidney test, Minute Full Kidney, and it's the only, and I don't think I've mentioned this yet, it's the only smartphone-powered home kidney test to receive FDA clearance. It's the first one and the only one today. So really cool device, and they're already working with a lot of health plans around the country, and they're actually partnered also with the National Health Services in the UK. So big-time stuff. Check them out, and if you want an introduction to them, on that feedback form, you could request it, and I'll personally email an introduction between Jonah and you so that you could ask him more questions about what they're doing. So Megan, I teed you up earlier. I want to talk about modeling around virtual care and last mile programs. And so how are plans, thinking about modeling around virtual care and supporting these new models around value-based care models, value-based care in the home?
Yeah, so I think when you talk about, virtual care, we started this conversation with it sometimes feels like it's disconnecting a member from brick and mortar or their primary care. And so I know our philosophy, obviously, when you're part of an integrated health system, we've got a lot of testing and learning, which then expands to the rest of the provider community that we work with and that members are engaging with. So we looked at an opportunity, and we've been in the virtual, product space for several years, first in the individual market and now in the commercial group with a virtual, first model. And so I call it very intentionally virtual first or virtual front door, because it is that primary touch point. However, we're wrapping it in that ecosystem of care that's brick and mortar. And so you have to have, right, not just acute care, not just primary care, but an entire sort of pod of virtual first that a member can access, and one that's communicating together, one that's communicating back to the plan, and one that's also communicating back to the provider. And so when I think you talk about those models, that also becomes just a really important place to say, meeting members where they're at. And I think that's the theme. If I could pick one out of today, we can help, build different things, but if you build it, it doesn't mean that they will always come. If it's not simple and you're not engaging with them in a way that's going to make them feel safe and trusted in that network. And then also you can't do it if you're going to build it in a silo. And so, there's also a model of care of saying we're asking providers in our communities to do a lot of great work in helping manage members. And there can be an intimidation factor of saying we're going to take them in a virtual first. Well, that means that they're not connected to us. And again, I think that being that pivotal place as the health plan, you have to create that connected model. And so being really intentional to do that, data becomes very important. And also making sure that it's a real-time connection and handoffs, right? So there's only so much that can be done virtually. How do you create that meaningful handoff? There's certainly a place for the health plan to be there. And then we also have to stay coordinated to the provider. Can I go just one other place, just because it was meaningful coming from, Pooja's component, and then also we were talking about health equity and financials. And if I were going to take it just one nugget of another place, it's also about helping providers and members understand cost and consumerism. And I know we haven't talked a lot about that today, but there's still a place to do this. And you can do that in virtual models as well, and saying that there's also a financial component to this that makes it really meaningful to a member. And so having them understand that there's an opportunity for them to save cost inside of these models becomes important. You can wrap that with many other tools like we do, and how they're accessing care, like our cost estimator, in which we've saved $3 million in member dollars, or I'm sorry, paid out $3 million in rewards to members while saving $13 million in claims. So connecting that with the providers, connecting that with the member, how people are accessing care, whether it's virtual or brick and mortar, there's two different ways to marry that.
What do you call that program? That 3 million, 13 million that you just cited?
Yeah, we call it priority rewards. And I would say we were doing cost transparency well before you had to. And so that's where we're saying there's many shoppable and opportunities for members to engage as a consumer in their care. So when they do that and they're going to lowest cost, high quality, we're going to pay them a reward in a card that they're able to use on whatever they choose to. So we save money as a plan, or employer does if they're covering that, and then members are also saving money and being rewarded for being savvy consumers. So 3 million paid out in rewards, 13 million in savings to the plan.
You held out on me during our pre-production meeting. Nice surprise. Early Christmas for Eric in our audience. So Jonah, as you're hearing this and hearing sort of the shift, even maybe thinking through virtual first models, how should service providers or vendors be thinking about partnering with health plans and sharing risk? What models from your perspective, how are you guys working and thinking about risk sharing from the service provider standpoint?
Yeah, thanks. So it's so interesting hearing everyone's perspective. I think you're right, Megan, that the theme is meeting people where they are to drive value at LTIO. Our motto is healthcare at the speed of life, right? So I think that the idea of what everyone's been talking about in terms of member engagement, making them feel welcome, trusting a source. It's all around creating value for that person so that they want to keep doing it. And how do we make these things sustainable? Everyone has to be deriving value. The health plan has to derive value from the intervention and the data that it's pulling in. The member obviously has to experience value from providing the data, like we were talking about before, from experiencing the intervention that is based off of the cohort that they're in, based off of the data that they generated. And then, Megan, you touched on it, but the other major player in this space is the clinician. And so making sure that they are deriving value from everything around, that's going to create that sustainability. And I think partnering with service providers around these data gathering points, around the intervention points that are really providing value for the clinician, is, as well as obviously the health plan and the patient, is critical, because that's not going to be a one-off. It's going to be, if that can be reinforced by the clinician, that's going to be the engine that can keep it running. Because if it gets stopped or blocked or pushed aside by the clinician, you lose that chain of value. And so, these large scale interventions. So I'll use Healthy IO as an example because it's what I know the best. But when we're able to work with a health plan, find all of the people that are needing an ACR test that year, engage that member, take that all of that work on, get them the kit, engage them in downloading the app. It's a super fun app to use. They scan it, they get the immediate result. It's a very kind of gratifying experience getting that immediate result, and then the call to action of getting it back to getting them back to the doctor to follow up on it, and also we take it on ourselves to get that result back to the doctor. Now, as a family doctor, what would I rather do? Would I rather be told to go find that person and get them in for their ACR test, try to get them to do it when nobody wants to go to the lab and pee in a cup? Or would I rather get the result and be able to engage with my patient with that result that's actionable? Now I can do something. Now I can treat my patient, have a conversation about risk. Now the plan knows about risk, the doctor knows about risk, and the patient knows about risk, and everyone is deriving value. So having organizations that are oriented around driving that value to all three parties and being able to deliver on that, as well as engaging around an actual financial risk conversation, I think is critical. And those are so if I would say, kind of to summarize, it's who's providing that high yield data point, and are they doing it in a way that is aligning value for everyone, for the patient, the clinician, and the health plan, and are they willing to take risk to be able to provide that in the highest quality, most efficient way? That's how I think about how do you engage the right kind of service providers.
Well done. Well done. I want to, there's been a big theme about going to where the individual consumer is. And so I want to go back to you, Pooja. Do you have another example of going to where the individuals that we haven't had time to share yet? Because I remember when we were talking, there was a bright spot that you had mentioned to me in our production call earlier this week that we have time, maybe you could share.
Yeah, thanks. I mean, these are such great ideas. I love hearing the stuff that you all are doing. We have a program actually called House Call 2.0, where we have a nurse that goes into the home with telehealth and connects back to a provider and provides care in the home for our high utilizers. I know we're not calling them high utilizers anymore, but people who are interacting with the hospital or the emergency room a lot. And the goal of this program is to do education, fill those social needs gaps, and also provide medical care until they can stabilize these folks enough to get them back into primary care. And the goal is always to connect them back into primary care. And this program has been really successful in reducing cost and also making that connection back to the PCP and stabilizing people so that they don't need to, continue to go to the emergency room or continue to be hospitalized. And we do try and find ways to do, like you said, Megan, virtual, to close those gaps and then connect people back to their PCP. And so we also work with Hazel Health to go and provide school-based therapy and also medical care in schools, and then connect those folks back to their primary care docs. And that allows us to save students from having to miss school, save parents from having to miss work, and still allow kids to be able to get the care that they need. So I think there's a lot of ways that we can support people where they're at to provide the care that they need and still keep that connection back to the provider. Because I think a large part of what we do as a health plan is to ensure that there's connection between providers, members, and their communities. And we can provide that convening role.
Great way to end it out. Really appreciate it. Big thank you to our roundtable group of experts. You were terrific. Thank you for all the time you spent with me preparing for this and for all the time today. You were excellent. Thank you to everyone listening, whether you're listening via podcast or right now live. We don't take lightly the hour in your day, whether it be weekend or weekday that you spend listening with us. We take that responsibility very seriously. We hope we continue to provide value for you. Please remember to take that feedback form because that helps us do our job. And please always remember that this is your Bright Spots in Healthcare podcast. Have a great day, everyone.